You asked me about the question on toxicity. As we know, toxicity profile is somewhat class effect with the PARP inhibitors. Hematologic toxicity dominates the toxicity profile of talazoparib. The gastrointestinal toxicity is not as pronounced. We also see fatigue. We also see some other unique toxicities with other PARP inhibitors. But I think in the combination of talazoparib plus enzalutamide, the main toxicity is hematologic toxicity, dominated by anemia. And I'd like to elaborate on anemia specifically for now. Grade 1 or 2 anemia was present in 55% patients before they entered the trial. And it really speaks about the aggressiveness of the disease in this patient population.
And were patients allowed to have transfusion to get them up to an adequate hemoglobin level to come into the trial?
That's a great point. So transfusion was not allowed during the screening period. And 40% patients developed grade 3 and 4 anemia on the trial. So in this HRR mutation positive patients. And it seems like a big number, but the fact that so many patients had grade 1 or 2 anemia to begin with, and if you look at the value of hemoglobin values, grade 1 or 2 anemia is up to 9 gram percent, and grade 3 starts at 8 gram percent. We really don't need a lot of drop in the hemoglobin to get to grade 3 and 4 anemia.
But was it different on the combination versus the enzalutamide alone?
Yes. So 40% versus enzalutamide was around 5, 6, less than 10% grade 3 for anemia. So definitely this is talazoparib effect. The practice relevant information in this regard is the grade 3 for anemia. If you look at the time to onset, median time to onset of grade 3 for anemia, that is 3.4 months. So it looks like most of these patients are developing anemia within 3 to 4 months. And then they were requiring dose reduction per protocol or transfusions. And once we reduce the dose in these patients who develop grade 3 for anemia, and by the way, median intensity of dose was more than 80% across the trial. So patients were not requiring more than 1 level dose reduction. And once we were doing it, the dose discontinuations were quite rare actually. In fact, only 4% patients required dose discontinuation because of anemia. So I think the toxicity discussion is so important whenever we discuss the efficacy of this trial because number one, it is so important for our colleagues out there in the community to know the anemia is common in this patient population. Is going to get worse when we start them on talazoparib, and it's easily manageable.
So do you have a recommended frequency for monitoring, especially in those first 3 to 4 months?
That's a great question. I think what we did in the trial was to monitor them on a monthly basis, more or less. I personally think patients who already have grade 2 anemia, and this patient population is quite common in the real world. More patients will have grade 2 anemia, in my view, than a clinical trial patient population, which is more robust, more healthy. I personally think we need to get at least a CBC every 15 days. And it can be done locally with the local labs. Patients don't even have to come to the clinic. At least 1 month follow-up in the clinic. That's what I would recommend, or I would suggest. That's what I have done in my clinic. And within 3 to 4 months, we will know who is going to develop grade 3 for anemia. Most of the clinical community colleagues, they deal with anemia and all those side effects in multiple cancer types. And they're very smart people. They know how to monitor these patients. They can easily figure out which patients are trending in wrong direction.
But our prostate cancer patients are often used to only coming in, let's say, quarterly, right? So it's a little bit of a change in practice for prostate cancer. And I think we have to forewarn our patients that we're going to need a little more intensive monitoring with this type of treatment.
With local labs. I don't think they have to necessarily come to the clinic because most of the patients will not develop grade 3 for anemia. So as long as we can order local labs, I think that's the only side effect which need to be monitored more often with talazoparib. And within 3 months, I tell this to my patients when I'm starting them on talazoparib with enzalutamide combination, that do these labs every 15 days to every 1 month. Usually I stop doing every 15-day labs after hemoglobin, I find hemoglobin to be stable after 6 weeks, for example. So it's very customized. But we don't have to have them come here for other side effects, such as hypertension monitoring or liver enzymes, as we see with abiraterone. So I think there are pros and cons of the combination.
And it sounds like there weren't any clear signals of more toxicity in the combination than you expect with either of the agents on their own, right?
Yes, absolutely. I'm so glad you brought this up. So we are not seeing more excessive toxicity because of enzalutamide or because of talazoparib. In fact, talazoparib dose was reduced to 0.5 milligram in combination with enzalutamide because the plasma level of talazoparib gets doubled when exposed to enzalutamide because of the drug-drug interaction. So I'm so glad that we found the right dose before starting the phase 3 portion. And I think as long as we are using talazoparib at 0.5 milligram with enzalutamide standard dose of 160 milligram, all we have to do is to monitor anemia closely, at least the first 2-3 months.